Of all the forms of inequality and injustice, health care is the most shocking and inhumane. Dr. Martin Luther King said that in 1966, and it is just as prevalent today as it was 50 years ago. In fact, probably more so, because today we know that so many of the health disparities that disproportionately impact communities of color in urban communities are preventable and can be maintained. We are thankful that in the last 25 years, under former President Bill Clinton, when he appointed Dr. David Satcher, that he had the right-mindedness to focus on health disparities. When he focused on those health disparities, and it's been almost 25 years since then, he focused on infant mortality, diabetes, the cancers, congestive heart failure, and HIV. Those health disparities still, today, disproportionately impact communities of color and communities in the urban core. I am so thankful for 25 years of research and science that today HIV and AIDS is no longer considered a death sentence, but rather it is a chronic condition just like those other chronic conditions that I outlined. Relationships matter. I am so thankful that in January of this year, we were able to bring on Frances Mills to serve as our program manager for the Office of Minority Health. Relationships matter. I met Frances probably 20 years ago. It's no secret that in November, the city of Cleveland was unfortunately confronted with the media around lead, our minority health program, and other challenges. I saw Frances in the hallways in the Department of Public Health, and I said, "What are you doing here?" And she told me what her role was. And I said, "I need some help. I have to reposition this department, and it starts with repositioning our programs that are vulnerable. Can I reassign you?" And she took that challenge, and I'm so grateful for her and the work that we have did in the last 4 months to turn that program around. Infant mortality. We are working with many of you, and if we aren't working with you, we want to work with you in our Moms First program and the work that is going to occur under First Year Cleveland. Relationships matter. It's for that reason that I'm so excited that I saw Teliandre, I don't know where she is now, but she has been a significant leader in infant mortality in our state. And now that she is in her new role, we know that she is going to take that same passion. Relationships matter. I saw Danielle Price, and I worked with Danielle Price in community benefits. And you know our communities cannot be economically healthy if we aren't healthy ourselves. Relationships matter. And now that she's over at UH, that has been an extraordinary partner to us on so many levels, I know that she too is going to take that same passion and veracity around communities of color and communities in the urban core for the work, the solid work that is going on there. Relationships matter. And I'm so glad that we have a representative from the Office of Minority Health here today, because that confirms for us, and that confirms for you, that we have repositioned our Office of Minority Health, and we're on a trajectory towards excellence in the Cleveland Department of Public Health. We are repairing our lead program. We are repairing our food safety program. We are repositioning and strengthening our infant mortality program. Healthy Cleveland is vibrant and being incorporated into the work of the department. We are so grateful for the 50 to 60 volunteers that for 4 years have dedicated time and talent to Healthy Cleveland. Relationships matter. We are grateful for that. A few weeks ago, we had our first convening of our Minority Health Advisory Council. And we have expanded that. Francis has expanded that to include not only African American and Latino American, but Asian American and Native American and any other American that is here that is considered in the minority health, so that we can touch on that, because the health of our society is contingent on us. And I'm so grateful that she has been able to expand out and reach out. And we are attempting to reach out to other communities, because we know that there are so many other communities that are relocating here, and the work that has been occurring with immigration. And we want to tap into those communities, wherever they're from. We want to tap into them so that we can make sure that they are healthy and vibrant and educated and employable, so that they contribute to this community. That's what this is about. And that is why Dr. King made that statement, because it is the health of a people that contributes to the economics of a people. And so at this time, I want to invite Amy here, and I see our good Councilwoman Phyllis Cleveland. I'm so glad that she has arrived just in time. But at this time, I want to invite Amy here, and I want to provide you with a proclamation on our Minority Health Month. And Amy is relatively new in the Ohio Department of Minority Health, and so I'm glad to give her this proclamation. But more than that, I'm glad to send her off with saying that because you all are here, because you all took the time to come and spend this day kicking off with us on our Minority Health Month, relationships matter. And so I want to salute you, and I want to salute Amy. Thank you. And I want to call up Councilwoman Cleveland. So Councilwoman Cleveland has been a Cleveland City Councilwoman for the last 10 years. She has had numerous leadership roles, and she has taken a personal role in women's health. So she's been actively engaged in the work that we do, and I am so glad that I have this opportunity to really introduce her. She has provided tutelage and leadership and mentorship for so many of us, including myself. And at this time, I introduce to you Phyllis Cleveland, the Councilwoman of Ward 5 for the last 10 years.
Well, good afternoon, everyone. Please excuse my delay. I serve on the Planning Commission, and we had a very long agenda this morning, so I ran out as soon as I possibly could. It's my pleasure to be here to open up Minority Health Month here in the city of Cleveland. Again, it's a wonderful, wonderful initiative. It's very important when we look at the state of healthcare and the state of health of our communities that we deal with and tackle and try to eliminate the disparities in healthcare and access to care and the conditions of African Americans, Latinos, and other people of color, other racial and ethnic minorities in our community. We are, just bear with me, get my bearings. And I'm going to say thank you to Chief Natoya Walker-Minor for going out of order, and she did a very good job, and she could do this. And also thank you for your kind remarks and your overstating my qualifications. I always appreciate that. We're going to move on with our program, and we have something, some really great things in store for you today. And first, I would like to bring up Maria Ritchie from CareSource, and she's going to make some remarks.
Good afternoon and welcome to the kickoff ceremony for Heritage Month. My name is Maria Ritchie, representative for CareSource. I'd like to acknowledge all of our community partners that are here today, and on behalf of CareSource, being a proud sponsor of Minority Health Month, because this initiative helps to identify health disparities, educate, and raise awareness about prevention in our community. At CareSource, we understand the challenges people face navigating the health system, and as one of Ohio's largest managed care plan, we work forth to put the health care in reach of the community that we serve. The national theme for this year is accelerating health equity for the nation, and at CareSource, we encourage the community to support minority health. So on behalf of CareSource, we welcome everyone. Thank you.
Thank you, Maria. Our next speaker is Francis Mills from our own Office of Minority Health for the City of Cleveland, Department of Public Health.
Good afternoon. Why should we focus on minority health? This was one of the first questions that was posed to me as I entered into this new role with the city. Why should the City of Cleveland focus on minority health? Why can't the city just focus on public health? This question was registered in on the office's Facebook page, and it caused a stir within the office because people really wanted to know who asked that question and how was I going to respond to it. For me, it's an easy question to answer, and for you, it's an easy question to answer. But the very fact that the question was asked draws attention to the importance, not only for the need for the Office of Minority Health, but for days just like this. As hard as it may seem, many people are completely unaware of the health disparities of persons of color. Along with my colleagues across the state, it is the purpose of the local Office of Minority Health to inform, to educate, and to empower recipients of care, policymakers, healthcare service providers of the health disparities that exist for persons of color in our respective local communities. Cancer, heart disease, unintentional accidents, stroke, homicide, liver disease, lung disease, kidney disease, suicide, substance misuse, abuse and addiction. These are the chronic conditions that disproportionately affect African Americans, Latinos, Native Americans, Alaska Natives, and Asians and Pacific Islanders. According to our very own Health Policy Institute in Ohio, our state is challenged with the ranking in the lowest percentiles for health value, healthcare cost, and population health. What this means for Ohio is that we smoke more, we have higher rates of diabetes, and higher rates of infant mortality. In 2014 in Ohio, while infant mortality rates decreased for whites and Hispanics, mortality rates for African American women actually increased. In Cuyahoga County, African American babies are 3 times more likely to die before their first birthday than their white counterparts. In the city of Cleveland last year, 83 infants died before their first birthday. In Cuyahoga County, African Americans are 4 times more likely to suffer from the increased risk of complications from high blood pressure. Health literacy is lacking, and cultural competence among healthcare professionals is at an all-time low. In the end, we pay for poor health. These disparities not only impact quality of life, but life expectancy itself. In Cuyahoga County, there is a 10 to 20 year swing in life expectancy depending on where you live. Health matters because place matters. If you live in the city of Cleveland or an inner ring suburb, you have a lower life expectancy than persons who live in suburban areas. Despite this ongoing need for awareness, education, and advocacy around the top 5 chronic health conditions affecting persons of color, there are other areas that demand our attention as well. STDs and HIV is one such area. For a long time, the impact of HIV was a persistent news staple and occupied the attention of media, health professionals, concerned citizens, and the faith community. Lately, it seems, the conversation has waned. As we began to plan for this event, we found that the issues around HIV are just as startling as they were back in the 80s. For African Americans and Hispanic men who have sex with men, this is a particular problem. In the United States, more than 1.2 million people are affected by HIV. However, the CDC recently estimated that 50% of African American gay and bisexual men and 25% of Hispanic gay and bisexual men will be diagnosed with HIV in their lifetimes. That's 50% and 25%, respectively. They go on to say that regardless of sexual orientation, 1 in 20 black men and 1 in 48 Hispanic men will be diagnosed with HIV. Naturally, as a result, women will suffer as well. 1 in 48 African American women and 1 in 227 Latina women will be diagnosed with HIV. This is not just a reason for concern, this is a reason for alarm. As you listen to our discussion today, please join us and generate similar discussions in your family, in your workplace, and in your communities. As long as there is a need for health equity, there will be a need for offices and advocates for minority health. Welcome, and thank you for your presence today.
Thank you, Director Mills, and thank you for laying out so clearly why there is a need for an office on minority health within the realm of public health. Next, I have the pleasure to bring up my colleague and good friend and brother in Cleveland City Council, and we've had the opportunity over the many years we served together to work on a lot of initiatives regarding the chronic issues of health and wellness within our communities. And so now I'd like to bring up Ward 9 Councilman Kevin Conway.
Hello, what key is that in? G minor? Okay, cool. Switch up to my musician mode real quick. There's 2 things I want to talk with people about, and let me say this first. Thanks for putting this on. And I know you have a series of events throughout the month of April. I'll be there supporting it, moving forward, the whole 9 yards. This piece is very, very touching to me, and it's very, very close to me. I thought that I was invincible just 2.5 years ago. I didn't eat any meat, worked out every day. Every day I'm at the gym, working out. Right, we were working out, pushing it. So I didn't think about going to the doctor, health, anything like that. Past 50, didn't even think about going there. I said, I'm cool, I don't need to go. So I ended up with cancer. I was in my 3rd stage of cancer, 3B of cancer. And I remember when you mentioned about matters, family matters, throughout this whole piece here, we're pushing minority health, but 365 days a year, family matters. Because when someone is with cancer or any kind of chronic illness, it doesn't just affect that individual, it affects family and friends. It matters, the whole piece. And I say that to say this right here. I was reflecting a couple of days ago, and I forgot this. When I was in the hospital, I'm not going to mention which hospital because they did a good job because I'm here. And I picked up some more weight, which is good. It's good when a cancer survivor picks up a little bit of weight. I remember I was given that excruciating pain in my stomach. I mean, the doctors would say, where you at from 1 to 10? I'm a 10, man. And so they gave me some morphine. And they gave me this little button, Phyllis, a little button to press. So the pain came, I pressed the button, click up. That morphine, man, I ain't gonna tell you. So I went to sleep on the morphine. Pain came back. Press the button one time, it doesn't work. You have to press it 2 or 3 times. So you press the button, click, click, click. Morphine kicks in. You know what I'm talking about. We all know what I'm talking about. Then my wife came in, Family Matters. My wife, Yvonne Conwell, she said, dear, what's this button for? I said, it's for the morphine. And it's making me feel good from the pain. So she talked with me. She said, dear, you got to push away from this morphine. And she used what I always talk about, Blaine. She said, if you're a man, you can take pain. She using my line on me because she always talk about manhood all the time. So when she left to reflect on me, and I started pushing away from it, from this morphine, because if I had stayed on it and you continue to press the button, the joystick, the feel-good button, you could end up in some issues. And then when they sent me home, they gave me, one of my prescriptions was OxyContin. I never took OxyContin to the drugstore because my wife and I had a husband and wife talk about the morphine as well as the OxyContin, because you could get hooked on drugs. So not only you have to take care of yourself, you have to watch your family members when they're dealing with illnesses as well. So you talk about minority health, how can you fit in to help? You have to watch the doctors, you have to watch the nurses to make sure they're taken care of, because if I had got hooked on drugs, I don't drink, smoke, or take drugs. But if you get hooked on it, the next thing you know, it pulls the whole family down. And it pulls the whole community down, which really hurt. Because, poverty comes out of the family. The riches come out of the family. Everything we hear today that we're discussing is family. So family matters to make sure that people are healthy. Well, I'm not going to give a long speech, but we got to look out for each other. And that's very, very important. And we have to watch out for one another. Family and friends is very, very important. And so that we can also do prevention. Because a lot of men don't like to go to the doctor. We play this macho stuff until we get down. And when we get down and sick, then we really sick when the man go down, because then we'll play the baby role. We'll play that manhood, but then the baby role will come in. So a lot of us are leaving, a lot of African-American males and Latinos are leaving because we play this macho role, but it's up to the children, it's up to your significant others or your spouses to make sure this man go to the doctor. Because I almost was gone, but I go now. If any resident call me and I have to go to the doctor, I said, man, I got to go to the doctor. I'll deal with you later. So I go now. Here's a takeaway piece, switching gears. And I mentioned this to the health director. You're doing a great job. You're doing a good job over there as the health director. I was listening to about lead, and you mentioned all these other issues. A piece came to my mind, because sometimes you wake up thinking about the residents in the city of Cleveland. The hospitals have a thing called community benefits. And I think, Danielle, you're there now. Are you there now? So you need to listen to me. The community benefits is for when poor people can't afford health care. Is that correct? So you kick in and you pay for the health care. Now we have Obamacare, and that pays for the people who are indigent and the people in poverty and in concentrated poverty that need benefits. Obamacare helped to pay for it. Now, if I am correct, because I'm not in your paradigm, then the community benefits money, you want to help out still in the community and in the neighborhood. When you talk with the health director, could we use, not now, but could we use that money to deal with lead issues, AIDS issue, obesity issues, and not let the hospitals decide how to use it, but we go there as a voice to talk with the hospitals to use it for the people, because they got to spend the community benefits money. It's mandated for the hospitals to spend it. If they're not spending the money, then we need to decide, because we need help with this lead issue. And we need help with AIDS issue, with a lot of issues. We got University Hospital there, we have Cleveland Clinic, and right around it is a lot of concentrated poverty. So we need help with that. That's something to chew on, to think on, and that's what I wanted to talk, Danielle, with your boss about. And I'll talk with the health director to see can we get some funding, because we need that. We got to come up with solutions. But anyway, thank you, and thank you for listening to me. And I always saying, God bless. God bless.
Thank you, Councilman Conwell, for those touching and real-life remarks of your experience. Next, I'd like to call up to the stage Bruce Kaffer. Did I say that correctly? Okay, and Bruce is going to do a traditional Native American prayer for us.
Mitakoyepi, Ampetu Ashte. I've said, my relatives, good day. In the Lakota language, my name is Wahachanka Yapi Yuhamani. This translates to walks with shield. I'm going to offer a Lakota song on this hand drum for the Circle of Life. We will offer this song together for the individuals and families and children that we have been thinking about that are affected by the many disparities of life on Mother Earth. We will offer this song for the men and women serving in the military. We will offer this song for their families, for those that have lost loved ones. And we will offer this song for all of life upon Mother Earth, as well as all things. In my job in the United States Department of Veterans Affairs, I have the opportunity to travel to different places in Indian country, and it is common in many tribal groups across the nation, as well as indigenous groups throughout the planet, that when we offer a prayer song, we stand. So those of you that are able to stand, I invite you to stand with me as we affirm our relationship with everything within the universe. Mitakuye Ayasin. Please be seated.
We're going to do some insights into this education. Right now, we're going to entertain you with a song that we have on one name. It's only got a number 7.
We'd like to get on with our panel discussion on HIV/AIDS in Cleveland and why the conversation has stopped. So I'm going to call the panelists up to the stage right now, and if they can take their seats. Pastor Max Rodas, Todd Wagner, MD, Dr. Wagner, Dr. Ann Avery, Tammy Jones, and of course our facilitator will be Tracy Jones of the AIDS Healthcare Foundation.
Good afternoon. I know we just ate, so y'all are a little sleepy, but we're gonna wake up because this is the important part. I'm delighted to be here today. We are so lucky to live in a city where there is a realization that we must take care of all of our citizens, and the least of which, right? Because it is easy to have the conversation about healthcare as a broad initiative. We really have to be granular and make sure that we think about those citizens that have the most to lose, that have the least to gain, and need the most all of the time. So we're delighted to have this esteemed panel today to discuss those very issues. I want to make sure, okay, everybody's got mics. It's really important because I wanted to give you a little context, and Francis did an excellent job and stole most of my thunder, so I don't have to do a lot. But one of the things that struck me when I was doing a bit of research was some numbers that the CDC actually has on its website. The southern states account for an estimated 44% of all people living with HIV and AIDS, despite having only 37% of the overall U.S. population. African Americans are severely affected in the South, accounting for 54% of new HIV diagnoses, which mirrors the Northeast. We used to say a while ago that DC had numbers that related to HIV that were close to sub-Saharan Africa. We are now sub-Saharan Africa. We've figured out how to do HIV prevention in Africa very, very well. But somehow, and I suspect that it has a lot to do with the fact that we aren't having the discussions that we need to have around HIV and AIDS in our communities, in our families, with our friends, with those opinion leaders. So I'm hoping that today is the jump start at the beginning of this year's National Minority Health Month to start to have those conversations again, and we're going to begin that today with this esteemed panel. Dr. Todd Wagner is an MD and MPH and the medical director of Care Alliance, one of our esteemed locations here in Cleveland. Dr. Wagner earned his medical college degree from the University of North Dakota, as everyone's aware. Pastor Max Rodas is the executive director of Proyecto Luz, and he is one of my dear friends in the struggle, and the organization responds to the health equities of urban communities in greater Cleveland. Tammy Jones, another one of my favorite people in the world, is the project director for the Cleveland Health Department, and she's the project director of the HIV/AIDS unit, and she oversees $2.8 million annually in federal funds. And Dr. Avery, who is an infectious disease doctor in Cleveland from the affiliated Metro Health Center and has received her medical degree from Case Western Reserve. Can we all give them a round of applause? We're going to start today's conversation with the question, and I would like everyone, if possible, to address it very quickly. Has the conversation around HIV and AIDS stopped? And if so, why?
So I'm Dr. Gregory, of the 4 people that I see produced. I would say yes, the conversation has stopped. We continue to see individuals coming into care that are afraid to talk to their families about their diagnosis. They remain isolated, and when they hear their diagnosis, they're kind of shocked because they really believe that HIV is not a problem in our community any longer. And although we continue to have this conversation one-on-one, we are not having it at a community level. So we're seeing the effect of that in ongoing transmission, particularly among our minority men. The young gay men particularly have very little social network that supports them, and as Councilman Conwell said, family matters. They're not able to talk to their families. So I think that it is important to bring the conversation back to the forefront.
Yes, the conversation has stopped. We do conversate among ourselves, among our community providers, among our current clients. And when you get outside of that network of people, that close-knit family, we're ashamed. We're afraid. We don't know what to say, why to say it, or how to say it. So my charge is to continue and to recharge my community, my immediate family members, my bloodline, my family members, through the struggle of community agencies and networks and co-workers, to re-educate ourselves, to find out what is really going on, to let you know that the person that you're sitting next to, if they're not affected with HIV, their friend is, their co-worker is, their family member is. So it is still here and it is among us, but it's closer than we really think it is.
I would echo the first one mentioned. I think the striking statistic is, despite the fact that we have we've improved access, we've improved management of HIV, more and more people are living longer with HIV, the number of new affected individuals has remained unchanged over the years. And there are still a striking number of individuals
many of you know me as an executive director of HIV Research Organization. But my response to that is a little bit different, and I don't think that the conversation has stopped. I think that the conversation never began in faith-based circles, because there are very few faith-based entities that really have had the courage to respond to the disease. They were trapped by theological considerations. They were caught up with political issues. I can tell you, I can count in my hand the number of faith-based organizations that have been strategically and intentionally committed to the issue of prevention and treatment of HIV.
Thank you. Along that vein, we're going to start with you, Tammy. Can you give us a little bit of information as what the profile of STDs look like in comparison to HIV in the city of Cleveland? And also, can you tell us a bit about what the city is doing, what their current prevention efforts are for STDs and HIV?
Currently, HIV and STD looks very similar. The face of HIV right now is men who have sex with men. Also, the black community at large, especially men of any sexual orientation. So that includes gay, bisexual, or those who are not identifying who they are. And also our youth, especially our minority youth. So while the profile looks the same, however, in the STD, we are really playing with, syphilis right now. That's an example of STD that is not age-specific. More of gonorrhea and chlamydia is heavily impacting the youth ages 13 to 29. So we do have, prevention methods within the city, within the community, that we're really pushing to eradicate these diseases. One of the things I'm going to say, and you're probably like, wow, condoms. We have forgotten about condoms. So condoms still work. We really want to push condoms. That is the ultimate barrier outside of abstinence that an individual can use. So we have them available, we make them available to our community partners, and they're free. They're free at our health clinics. Also, PrEP. PrEP is a new prevention strategy that is being used. It's a once-daily pill to prevent HIV. So individuals who may engage in unsafe sexual practices with another person, there is, assistance for you. We're also wanting to push testing. Individuals need to get tested. Testing should be a part of your regular routine medical maintenance. When you go to the doctor for your annual checkup, your doctor should be asking you about your sexual health. You should also, in your lab work that you get in your yearly tests, you should also be getting tested for HIV. If you're not, you need to question your doctor as to why. That is something that we really want to push. And we're not telling people that they cannot engage in sex. Sex is a natural union among humans. What we want to spread is safe sex. There are many ways that you can enjoy sex, utilizing condoms and the various barriers that we have made available, that are available to us. We want to, my goal is to really educate. If you're educated, then you have the tools and the resources to be able to make healthy lifestyle changes for yourself.
Thank you. Dr. Avery, 2 questions. What are the barriers that you see to persons of color accessing care? And tangential to that, what are the methods of methods that HIV and healthcare professionals can use to improve the rate of entry into care?
Thanks, Tracy. So the barriers to care for our minority community are very multi-level factorial. I think that there are things like simple things. Transportation is more difficult. Getting a bus ticket and getting to a clinic may be more challenging for someone that's living in high poverty. It may not be a priority because campaigns to try and get people aware that HIV is not like it used to be. There are great treatments out there for both those who are living with HIV and those who are at risk but currently HIV negative. We want to keep them in.
Thank you. Thank you. Dr. Wagner, your population is pretty unique and the challenges are specific. Could you speak to us today, in your opinion, does housing instability increase the risk of HIV infection? And also, what are the greatest needs for the homeless HIV persons that you've seen this year?
Without a doubt, the lack of housing instability does increase the risk for HIV infection, even when we control for behavior and other factors. Housing itself, the lack of housing, is an independent risk factor for it. We see that within certain groups, for example, IV, those who use IV drugs are less likely to engage in needle exchange programs, more likely to share needles and participate in risky sexual behavior if they're not housed. And with other at-risk groups, youth and transgender individuals, we see that they're more likely, if they lack housing, more likely to participate in transactional sex, oftentimes just to survive and have a shelter over their head at night. So these all increase the risk for STDs and transmission of HIV. Without a doubt, the greatest need for the homeless with individual with HIV is housing. It has that big impact on their overall health and their HIV care. And so we have seen improvements with the expansion of Medicaid eligibility. It is easier to get individuals on medication and to get their viral loads suppressed. We can do it quicker than we would before, but we're utilizing vouchers and applications for pharmaceutical programs. But it doesn't necessarily address the housing issue, and there's still an unmet need here in Cleveland for that.
Thank you. And finally, Reverend Max, can you talk to us broadly about the faith community and what's your greatest concern regarding the church's role in HIV prevention and treatment as it relates to LGBT people, young people, and the discussion of sex?
I'm trying to summarize it. I'm a preacher, so I talk long about it. Father Bianchi, in his book, What's So Amazing About Grace, says the following. He says, it is easier for a gay man to have sex in a nightclub than to get a hug in the church. And I would encourage you to just let that marinate in your spirit and in your mind. While we have exhibited in the church as a total lack of hospitality, my wife continues to tell me, she's also a clinical person, she says, Max, people don't care about what you know. And then preachers need to hear that, and leaders in the church. People don't care how much you know until they know how much you care. I think one of the greatest struggles that we have had is one of the things that I'm terrified as we continue to look at this issue of HIV. HIV is the only political disease. If you would go raise money for any other disease, any other chronic illness, you're a good person. But if you're raising money for young men of color who are infected with HIV, who happen to be MSM, you all of a sudden become suspect because you are addressing a cause that nobody wants to talk about. I think that it's time for us to have that conversation. But one of the biggest fears for me is three things. Denial, our ongoing denial of what people who are infected with HIV who are in our churches on Sunday morning. Number two, the disengagement. We continue to be disengaged from the LGBT community. And the most terrifying thing for me is the demonizing of sexual health. We continue, you're hearing the rhetoric of political discourse right now in terms of public health. It's the same stigma that we have about mental health, right? We can talk about physical health, but there's something wrong with us if we have to take medications for mental health issues. I think that it is time now, it is time for the church to have conversations in the church, but we must have that conversation. Incidentally, and I speak as a Latino man now, ethnic churches are notorious for being not hospitable to people who are HIV infected and who happen to be gay.
I appreciate the robust discussion, and I'm hoping that you all will take, as Pastor said, and marinate on his words and the words of all of the other esteemed panelists. And this is hopefully our beginning to have that conversation, remembering our relationships, as the chief said, using those relationships to dispel some of the rumors, innuendo, and stigma around this disease and this important time in our lives, considering what we are facing as the circus comes to town, for lack of better words. I appreciate you. I have enjoyed this day, and I will turn it back over to Councilwoman Cleveland.
Okay, we have another performance. It's a dance called June Lotus by Yen Tang. And Yen Tang is one of Cleveland's premier Chinese choreographers and dance directors.
Good afternoon. Hi, everyone. My name is Yen Tang, and as I'm sorry, I didn't catch your name.
Councilman Phyllis Cleveland.
Oh, yeah, that's right. We've met once before. But anyway, as she mentioned, my name is Yen Tang, and I've been doing traditional Chinese dance around Cleveland for a couple of years, since 1999. And today I brought you a dance that is a cross between two different classical forms. One's from the Qin Dynasty, and one's from my costume is a little more modern. It's a Han-style costume, but the fan is what's from the Qin Dynasty. And with the welcoming of spring, I decided the song June Lotus would be appropriate for today. I hope you enjoy it.
That was beautiful, and what a wonderful way to wrap up this celebration of culture and heritage. We want to thank each of you that stayed. We know this went a little long, but we just want to thank you for your time and effort. Today we talked about health literacy, social determinants of health, access, place matters, cultural competence. We learned a new acronym, proper education always corrects error. We talked about the need for us to be human and to have the human touch with one another, irrespective of any medical challenge or social situation that we find ourselves in. So as we leave, and I'm a preacher's wife, we can reach out and touch somebody's hand. Let's make this world a better place if we can. Thank you and God bless you.